Welcome, everyone. Today we will have different topics, and we will start with Dr. Maya. Dr. Maya is a chief resident, or she will be in a month. Or welcome to our program, Dr. Maya. She was a graduate from this program. Please welcome.
Yeah. Thank you so much, Dr. Nader. Assalamu alaikum, everyone. Hello, I hope you all are doing well. Dr. Nader, we can wait or do we start now? We can wait for a few minutes if everyone
Okay.
join. Yeah,
All
then
right.
we can.
We can.
Yeah, perfect,
Yeah.
perfect. Yeah.
No
Mhm.
problem. Thank you so
Thank you
much
very much
for coming.
for giving me this opportunity again.
Oh, sure. Yeah. Always we are having fun with you, and it's a pleasure to have you. So
Thank you very much.
thank you. So I'm gonna share the agenda, and then maybe we can start. Let me see. So today we're gonna talk about different topics, as we mentioned. Welcome to the program. We'll start with Dr. Maya, and follow that we will talk about gait abnormality, and then we will go over some of the databases that can be used in research in the US. Also, we'll talk about how to write a winning abstract, followed by styling references, like when you write a manuscript for a journal. So without ado, we're going to start with Dr. Maya. Welcome to our program, Dr. Maya, and
Thank you
thank you
very
so
much, Dr.
much.
Naren. Yeah, thank you so much. So, hello everyone. Again, my name is Dr. Maya Adwani. I am one of your fellows. I used to belongs to Green Team. When I was in telegeriatric, I got meshed into my residency program in 2024 and successfully graduate from this fellowship, telegeriatric fellowship in 2024, and started my residency. First of all, I would like to again thank you to Dr. Nadir for everything, for mentorship, for efforts, for help, and everything. I'm 100% sure this journey wouldn't be possible without his help. And I'm today telling you all like this is like I'm 100% sure you are on a right path because this platform where we are doing research with Dr. Nader, telegeriatric, this platform is a very established program, and here we are making connections, polishing our skills, and I don't see any one else is doing efforts like this. I don't see it. Maybe I wish. Like when I will be something like as attending, maybe I will start to do the like Dr. Nader, help other people, but nobody is doing this. So please take advantage from as much as possible. I'm your fellow. We are still connected with each other from these programs. Like from my group, we are almost everybody got meshed. One or two maybe left, but we are still connected. We are still helping each other. I can take names like Dr. Sama Eman, she met last year. So we are still connected. Dr. Tahani, Dr. Afra, Dr. Asma, we are still connected. We are still sharing our ideas and our efforts with each other, how to improve, how to succeed in our next step. So currently I'm PGY2 resident at White County Medical Center, Unity Health, Searcy, Arkansas, and I will be going to start my PGY3 next month. And I'm also honored as a chief resident in my program. So I'm like, I was not, I was in your shoes not too long ago. I was like you, collecting my letter of recommendations, doing efforts, doing my observership, externship, So it's very important part because this path is not easy. I'm going to tell you, this path is not easy. We have lots of obstacles to beat. We have to do extra efforts because we are coming from different parts of worlds, so we have different kind of knowledge. We all have some weaknesses and some strengths, so we have to figure out what we have to improve our weakness, how we have to improve our weaknesses. So as I'm also old graduate, I moved here in United States in 2015, 2016, and got meshed into residency program in 2024. So it took me 8 years, I'm originally from Pakistan. I moved here. I already finished my internal medicine residency in Pakistan. So when I got married, moved here with a little kid, it was not easy for me to start again all over, to work on USMLE, and but like it's not impossible. I'm going to tell you guys, it's not impossible. It's difficult, but it's not impossible. So I finished my steps. I did my observership, externship, and also I worked as a CRA, like a clinical research associate at University of South Florida. I also started working there, and then I got matched into my residency program. So um, I'm here. If you guys have any questions, or want to share something with me, or do you need any help from me, I would love to help you guys, because we are fellows and fellows forever. We are not just graduating from this tele-geriatric program and we are done. No, we are always fellows. So please reach out to me when if you have any questions, or now if you want to discuss with me any kind of ideas. I'm here for that. Um, uh,
Thank you so much, Dr. Maya. Can you tell us more about Harvard? You already took some step there.
so what Dr.
Harvard.
Nader?
Did you do any extra like certificate in
Yes.
Harvard or something?
Harvard, I didn't do certification with Harvard, but when I started work with as a job as a CRA, research clinical research associate, I obtained some few certificate like good standing, and also research related certifications. But in my program, how I because I matched, Dr. Nader, I matched into soap, not in a regular match. I did not match in a regular match results. So I match in a soap. Then I had no connection with my programs. My program only takes their graduates, nearby graduates. Like I'm in Arkansas, so they take Oklahoma and Mississippi, those kind of graduates. But I applied, no connections, and I got matched. I don't know how, but I'm thinking my everything was like my positive thing in my resume was my work, because I also recommending everyone. I know everyone is trying good to obtain a good scores in USMLE. I'm sure scores are important, but beside scores, other things are very very important, to do observership, externship, because I got matched into second cycle, and my biggest mistake in first cycle, like I had the LOR, good LOR from Dr. Nadir, from other attending physician. I worked there, but sometime you had to be get the LOR which stand out, Dr. Nadir LOR were ama- amazing, fantastic. And then I got in my first cycle, I got two interviews, and one of one PD from one hospital, he told me, yeah, I liked your resume, I liked your work, but I'm unfortunately I'm not going to give you position. I'm going to tell you right away. But what can it is possible to give you a good letter of recommendation as a PD. So maybe it will help you, like in you apply, like in other programs, maybe it will help you. But like I can do that for you. Like I'm able to give you a good certificate, because on the basis of your interview, on the basis of your resume, you are a good candidate. But don't, like I'm not able to give you residency in my program. He told me straightforward, it's not possible to, like it match into my program, but I can give you a good letter of recommendations to stand you out. So then that PD gave me a good letter of recommendation. In second cycle, I had the four LORs, one from Dr. Nadir, one from that PD, and two from other attendings, which I worked with the infectious disease, and also one with oncology, hematology and oncology department. So I don't know what he wrote down for me in that letter. And I also polished my skills, like doing a research job. And also, beside observership, I did my externship as well at the University of South Florida. So I think combination of all, and I was fellow here in telegeriatric. And in both time in my interview, everyone asked about this program, what you guys are doing, how you guys are putting efforts in research. You guys are just doing work, or publishing article as well. I said, no, we are publishing, because I had the two publications that time. So it was a proof. We are not just attending meetings, we are putting efforts, we are working as a research fellow. And it worked out very well, and they liked my articles was stand out in that interview. Like a 10 or 15-minute talk was all about telegeriatric. So it was a very good, because it's not easy to buy 15 minutes from PD or associate PD to talk about something. So that means like there was some work to talk about. So I was glad. So when I matched into the program, my main focus was, because I was not everyone was new for me in that program. No connection, no IMGs even in my program. All were their own graduates, and it was very difficult to dig into the pool, what's going on, how to interact with them. I'm sure, I'm from different parts of the world. I'm originally from Pakistan, so my English was not first language. So it's difficult to communicate with pure English people, pure own Americans. So but it's not impossible. You have to work hard. I was always available for my program in any difficult time. Whenever there was shortage for residents, no one was available for duties, I say, yeah, I can do it, because I was not doing to get something from them, but I was doing to polish myself, to learn more about program, to learn more about medicine, to learn more about people. So it worked out well. And when there was a announcement for chief, so there's a criteria. They say, we are going to conduct a meeting. We have faculty meeting, and if anyone interested, you can apply. So I was not sure. I said no. It was not on my list as a chief. But my PD told me, you are a good candidate, I want your application. I got surprised. I say, okay. I then fill out the application, and the faculty and did the meeting, and the resident did voting, and they chose me as a resident. I'm very glad. I'm thankful. But thing to tell you guys, always be willing to work, because I know we everyone have skills, but we have to hidden skills. We have to expose. We have to expose those skills, work on it. Even weaknesses, we don't have to hide our weaknesses. I know if our English is not our first language, so we are always kind of worried about how we talk. Maybe we are not talking right. Maybe we do mistake. It's okay. It's okay to do mistakes, because that's how we learn. Um, uh, and willing to work always, because it work out for me. I'm very famous in my program. I'm always willing to work. So I think this is a good way to start. And don't worry about technology. We are all graduate. We always have fear. Maybe we don't know how to operate EMR, how to talk to patient. No, this is a thing of only 15 days. When you get mesh and you attend your orientation for 1 week and work in the hospital next week, in 15 days you will be okay. You will understand whole environment. You will be okay with software and everything. Because the biggest fear in our IMGs, international medical graduates, we are coming from different parts of the world. So we have always fear, maybe we don't do good. No, we do very good, because we have skills, just we have to work on it. I think so, this, especially this platform, telegeriatric, it helped me a lot. It helped me a lot. It's not a very simple or common thing, so don't take it light. Please put your effort, everyone. Dr. Nader is doing too much for us. It's not possible to give time to without any like Dr. Nader don't have any expectation from us, no expectations. Who is doing in this world without expectations? But we have to take advantage. We have to uh, connect with each other, share ideas, and I think everyone will match, because it's not. I am seeing we had the group of 7 people from this telegeriatric. We all matched. I think one left. She will be matched next year, inshallah. But no one will going to be student for forever. We all are become a resident, then become attending, then become a full-fledged doctor here. So yeah, so work hard, put your efforts. Everything is possible. It's difficult, but it's possible. Mm.
Sounds good. Thank you so much for sharing all these tips and advice. Any questions from the group? And congratulations for being the chief resident. It's a big thing.
Yes, thank you very much. See all your efforts. You are a good mentor. I still remember when I was applying, because in Pakistan I did my residency in internal medicine, and in Pakistan we only do internal medicine and other specialty. We don't have the family medicine residency in Pakistan. No, there was no concept. I did my electives in OBGYN, pediatric, but there was no concept for family medicine residency in Pakistan. So when I discussed with you, you told me you open your options, you had to apply in family medicine. I was very hesitant, and you was the only person for the guidance and mentorship that time. I would always grateful. I'm always giving you blessings, and I would love, I'm loving it now. Like family medicine is a very good specialty. I know some of us are very keen to pursue internal medicine, because I was also, I after getting matched into residency, I asked you, Dr. Nader, it is possible to do internal medicine. You say, yeah, maybe after family medicine residency, you can do internal medicine. But now my perspective is changed. I don't want to do internal medicine because it's a great fit for me, for my family, and I already decided to do fellowship in geriatrics. So I'm loving it.
That's very, very good to hear. I'm very glad.
Yeah,
Thank you
I'm
for sharing this.
satisfied. Yeah, it's very important. You are doing something, you must be satisfied.
Oh, sure, yeah. And
Yeah.
Geriatric is a good option. So hopefully you will
Yeah.
go there and you will help a lot because in this country and all over the world, many people are getting older and
Yes.
we need
And Dr.
good
Nader, I'm
doctors.
from Florida. So Florida is a very, we have lots of
Mhm.
geriatric population. So eventually
Sure.
after residency, I'm moving back to Florida. So I think it's a
Mhm.
great fit for me.
Sure.
Yeah.
I'm very glad. I'm very happy for you.
Yeah, thank you so much. Yes, my
Thank you.
fellows, if you have any questions, if you want to reach out with me later on, I am happy to help you. I'm here for you always.
Thank you so much, Dr. Maya. Would you mind sharing your email just in the chat if you can
Yes,
write
Dr.
your email?
Nabi. Yeah, sure,
So
sure. Yeah.
if any of the fellows in this group or later on they can reach out.
Yeah, sure, Dr. Nadin, right now.
I just wanted to thank you very much, Dr. Maya, for all of these advice, and thank you so much for your time, for your support, and everything. This was very encouraging speech, very positive, and full of hope speech. Thank you so much.
You're
I
very
just wanted to
welcome.
ask, yeah,
Yes,
just one question is, so now we're in June. We've got like
yes.
almost 2 months and a half, maybe, or 3 months until the application. So, what would you advise us to do from now?
From now, you are, you have to work on externship. Observership is okay if you are getting, but externship is very important because from my experience, whatever we did in our back home is important because that's why we are here today. But things we are doing right now here in America is very, very important because interview is all about you have a great source like you are going to talk about this telegeriatric medicine research opportunity and your articles. This is a great opportunity and great thing. You also have to you are lacking in a clinical part because you have research part with you now. You have articles. You are going to talk about this program. This platform is amazing, but you also need clinical portion which we are lacking. So start hunting any program is going to give you opportunity even for 15 days or 1 month to do externship where they will allow you to see patient yeah, and round with attending physicians and discuss with cases is very helpful because they maybe ask you about rare cases. If you work with some attending, you saw some rare diseases and rare diseases and management, so that means you have something to talk about.
All right. Thank you so much.
You're
Thank you
very
for your
welcome.
advice. I really appreciate that.
Yeah, any externship, any job opportunity, any research job is very helpful. It's very helpful because you have something 50% you have already because you are going to apply your application, your research article, you are going to talk about this telegeriatric what we are doing here, a presentation and everything, but you need a clinical component. In a first cycle, I was lacking in a clinical component. I did some observership, but no externship, no any job. So I improved in next cycle. I started my job as a CRA, clinical research associate, and also I did externship. So I think it worked out for me.
Okay.
I could
Mm.
add to Dr. Maya's answer, this great one, is what I did in the past. I joined a hospital nearby.
Yes.
So what I did to go through the door is I did volunteering. And once I'm in the system, I went to the ER doctor and I told them, can I round with you? Just observe. While
Mhm.
I'm doing that, I learned a lot about the EMR, how to deal with the patient, the family, and so on. And I did not go far apart from that. But if you reach that point, you can talk about, can I do like present a case for you or whatever considered externship or part of the rotation. It shouldn't take you long, a few weeks, as Dr. Maya mentioned. If you round with more than one physician, that might be better. If you show them you know something, your skills or your discussion or your thinking, critical thinking, all this matters to the point. If you ask them, if you want to write me a letter in 2 weeks, what should I do? So in these 2 weeks, you show them something, cases or maybe just helping, and then they can write about your discussion, your case presentation, or helping this and that. There are some hospitals, they have very limited like approval. So you might face the difficulty that they say we need you to have this or that or through the school, the medical school, or whatever limitation, but you try your best, go through the back door if you want to. And it's going to be two for you. So it's going to be considered the volunteering part. And if you access either the the emergency medicine or the medicine or whatever during your rotation at the hospital, you can do that. And it's going to be like the clinical observer Dr. Maya was mentioning. Thank you.
Absolutely, Raghad. Yeah, absolutely. You are right. Because as I told you, I had the interview and PD told me I can give you a letter. And for the letter, like, he didn't give me right away. I emailed that PD, can I do externship with you? And she allowed me. She said, yeah, you can do externship with me. I said, for how long? She said, till whatever you want, because she liked me, she liked my work, but she was not able to give me residency position. So I worked with her 4 months, like, externship, and I was presenting cases with her. And when I emailed her for my letter, she emailed me back, you have to write down what cases you seen with me, like, you have to mention little bit detail about it, because I'm going to give you personalized letter. So I think it was worked out for me. I had the Dr. Nader letter, research letter was covered 50%. I was lacking in clinical, so I think that letter and my research job like compensated by that one. So, and my next, like, request to you all guys, when you are selecting list for applying programs, don't randomly choose programs, because things are different now. Before we were thinking we have to select those programs who have IMGs in it, who are not focusing on scores, maybe programs like those programs who are not focusing on scores, or maybe who the program who have lots of IMGs. I don't think so this criteria is working now. I think so you have to see programs, those programs, small community programs where people are not able, like, not interested in going. And like my program, I don't have direct connection from this Arkansas to Tampa. So I have to take 2 flights to go to see my family. So those kind of, like, I know it's difficult, but those programs are for us, for old IMGs, because we have to pay a little bit extra efforts. Is because we are all graduates, so we have to do something little bit extra than new graduates, and so try to narrow down a list of small community programs, and don't focus on big hospital, university programs. They are not going to accommodate us, because to be honest with you, it's a wasting of time. Unless you are fresh graduate, you graduated last year or year before, you have very good scoring, like 250, 230s, 240s, in three steps, like, USMLE step. Otherwise, if you have any, like, I'm not going to say those are weaknesses, but if you have, like, those kind of points, all graduates, you have a basic scores, like, not too high scores, you have to try to focus on a list of community programs. They may, as I already mentioned, my program 5 years ago, they were not going to take any IMGs. From 5 years, they are taking 1 or 2 IMG every year. So it worked out for me. No connections, nothing. I was like just apply in SOAP, even not in a regular. I was narrow down program in my SOAP time. I just selected programs, small community programs, no any university program, and it worked out for me. So if in this fellowship group, those are all graduates, have low scores, please like focused on small community programs. It may be worked out for you as well.
Okay, perfect. Thank you so much, Dr. Maya. These were very important tips and practical, like very practical tips that we need to follow in the future. Thank you so much.
You're very welcome. And next, don't take soap like very lightly. Soap is, I think so, everyone have different experiences. From my experience, soap is more important than regular applying match, because I match in soap. My other friend last year match in soap. So I think soap, don't take soap, like, when match result is out, God forbid, if you are not going to match, don't think this all over. No, it's not all over. It's still there. Maybe your chance is still there, and your chance may be more higher than regulars, like, applying match. So don't take soap very lightly. Try to focus on participate in soap in very, like, in a full manner, more efforts than regular match application. Like, try to reach out to the program, try to find out sensibly the small community programs, try to focus on, don't apply the program who have 2 seats, try to focus on a program who have 8 seat, 4 seat left. And so your chance of matching is higher by choosing those factors.
Dr. Maya, can I ask you 2 questions?
Yes, yeah, please.
Okay. How did you use your signals? Is there signaling still in?
Yeah, to be honest with you, in when I applied in 2020, yeah, 3 or 4, like, cycle, that time signal thing was new. And we just have to, like, there was nothing. I think nowadays is a gold and silver signal or something. Yeah, I heard about it. But when I applied, there was an option to just signal program where you want to go.
Oh, okay. Yeah, because they
Yeah.
said that the reason why the match system has changed, it's because of the
Yes.
signaling thing.
Exactly. Now
Yeah.
they are more narrowing down by
Yeah.
putting this criteria. But during my time, there was no gold or silver signaling, just was
Oh.
signaling. And it was the first year they started giving signals to the program.
Yeah.
Yeah.
Thank you.
Yeah.
And the second question is, so for as much as I read about it, they said that you're more likely to be taken if you have either a green card, or you're in general just a USIMG. Do you have those?
Yes.
Or yeah?
Yeah, you are right. But few programs still take visa people. Like
Okay.
in my program, they were not giving visa. Like, their main focus was citizen, US citizen, and green card holder. And I got advantage because I was citizen when I served. But now it's not 100% like, fixed, because when they are short with the resident, when they are not finding, they are also sponsoring visa. Yeah.
All right. Thank you so much. Thank you. That's
You're very welcome.
Thank you so much.
You're very welcome. Yes. Any other questions for me?
Thank you so much, Dr. Maya, for all these important and useful tips. We wish you all the best, and I'm sure we're gonna meet again, and hopefully we'll hear good news. Congratulations again about your chief position.
Thank you so
Thank
much,
you so
Dr.
much.
Martin. Thank you. Thank you so much.
Have a great day. I really appreciate that.
Thank you so
Thank
much.
you.
Assalamu alaikum, everyone. Yeah. Good luck to everyone. Yeah. Thank you.
Thank you. Have a wonderful one. Thank you. Assalamu alaikum.
Wa alaikum salam.
Okay. I think Dr. Ayah,
Yes.
when you are available, maybe you will be next.
Okay. Hello, everyone. My name is Ayah Abdalla, and I'm the team leader for Forest Green team. We will be presenting today's agenda. We will start by the first topic, which is Gait Impairment, with Dr. Mylene, and that will be followed by Dr. Raghad, and then followed by Dr. Nabiha. And finally, we have the part that I will be talking to you guys about how to present a successful abstract in a conference. Okay, so this is all about today's agenda. So, Dr. Mylene, if you're ready, we can start now.
Yes, I am. Hi, everybody. Hi, Dr. Nadir. Okay, so just a minute to share my slides. Is everyone able to see my slides, and can everyone hear me as well?
Yes, we can hear you and we can see the slides clearly. Thank you.
Okay, so good evening again, everyone. Well, depending on where you are. Today I'm going to be presenting on gait impairment. My name is Mylene, and I'm happy to share this presentation with everyone today. So moving on. So the objectives of my presentation, I hope that by the end of this talk, everyone should be able to know how to perform a diagnostic evaluation of gait dysfunction, how to conduct a gait assessment for an older adult, and how to understand the interventions that can possibly reduce gait impairment. So before we begin, I just want to start with an introductory case. This is just going to give us a brief overview of each step to take when we encounter a patient with a suspected gait disorder. So it's a 63 years old man. He's brought to your office by his spouse for an increased tendency to fall, especially when turning around the corner to reach the refrigerator. Before I continue, sorry, this is credit to the American Academy of Neurology. I got this case from their site. Yeah, I just needed to share that first. So his spouse also reports that he cannot keep up anymore during their walks around the neighborhood and that he walks funny. The patient insists he's just old and clumsy, but decided to come to you upon his spouse's insistence. So what are the neurological causes of gait impairments? We have disorders of motor function, of sensation, and of coordination. And in coordination, we have the subtypes of vestibular dysfunction, cerebellar dysfunction, and extrapyramidal dysfunction as well. The patient's particular comments, such as his tendency to fall while turning, his slow speed, and walking funny, it seems to suggest that he has some form of gait impairment. So, how do we determine the etiology of a patient's impairment? The next step is to conduct a comprehensive neurological exam. So you want to make sure you check for the patient's ocular function, including the extraocular movements, as well as the upper and lower extremities. You check for the tone, the strength, the sensory exam, as well as the deep tendon reflexes of the arms and the arms and the lower limbs. Cerebellar function as well. You check for finger to nose test, heel to shin test, as well as rapid alternating movement. Most importantly, we have to observe the gaits. We need to pay attention to the patient's posture, the base, that is the distance between the patient's feet. We also need to look at the speed of the walk, the stride length, the arm swing and turning as well. Be sure to also check walking on toes and heels, tandem gait, and Romberg test. So on physical examination of a patient, we noticed a 5 on 5 strength in his legs, intact sensation to pinprick, temperature, vibration, and proprioception, 2+ reflexes, normal heel to shin test, increased tone, slowed rapid alternating movement with the right hand. On timed up and go test, we're going to look at this much later on in the following slide. You notice a stooped posture, normal base, slow pace, shortened stride length. He does not swing his arms and keeps his elbows and knees flexed. When turning around, he does not pivot smoothly. Sorry about that. He does not pivot smoothly to face the opposite direction, but instead he takes several steps. You also notice a slight tremor in his right hand when he walks. After performing the physical exam on the patient and examining his gait, you recognize his gait is most consistent with Parkinsonism. So Parkinsonism is it's defined by bradykinesia, that is slowness, and other motor and non-motor features, including gait changes and rest tremor. The most common cause of Parkinsonism is Parkinson's disease, but it can also be seen in like dementia with Lewy bodies, vascular Parkinsonism, and also drug-induced Parkinsonism. In a particular case, we're able to rule out any dysfunction in the cranial nerve, strength, sensation, reflexes, and coordination. So all of these were normal in these patients. This helps rule out other causes of gait impairment, which we're going to look at in the coming slides. So we have that as a framework of what to do when we see a patient with suspected gait impairment. So the topics covered now, we're going to start our presentation proper. We're going to look at the epidemiology of this condition, conditions that contribute to gait impairments, assessment of gait, and also interventions to try to reduce these disorders. So epidemiology of gait disorders. Gait disorders are common and are a predictor of functional decline. Gait impairment is a highly age-associated multifactorial condition. It affects roughly 10% of adults in their 60s and over 60% of those aged 80 and older. Community-dwelling older adults with gait disorders, particularly neurologically abnormal gaits, are at higher risk of institutionalization and death. So this is a guide to abnormal gait patterns. So these are different patterns in abnormal gaits. First, we have the antalgic gait. This is a pain-induced limp, with shortened stance phase of gait on the painful side. So the patient is going to avoid standing on the painful side with this antalgic gait. For circumduction, there's outward swing of the leg in semicircle from the hip. And then we have festination. This is the one that's common in Parkinson's. Acceleration of gait. We have foot drop, loss of ankle dorsiflexion secondary to weakness of ankle dorsiflexors. We have foot slap. It's an early, frequent, audible foot floor contact with stoppage gait compensation. Echinovarus, it's excessive plantar flexion and inversion of the ankle. Freezing of gait, sudden short duration diminution or cessation of walking, usually associated with shift in attention or movement circumstance or direction. Genu recurvatum, it's hyperextension of the knee. We have propulsion, the tendency to fall forward, retropulsion, the tendency to fall backward, scissoring gait, it's hip adduction such that the knees cross in front of each other with each step. We have the steppage gait. It's an exaggerated hip and knee flexion and foot lifting that's usually accompanied by foot drop. We have the Trendelenburg gait, shift of the trunk over the affected hip, which drops because of hip abductor weakness. And we also have turn and block. It's moving the whole body while turning. So I tried to find some illustrations demonstrating these various gait abnormalities patterns because I like to try and be visualistic sometimes when I try to study something. So for the antalgic gait, you can see on this picture, on this, the affected side is a bit concave, if you can notice, and the patient tries to not put their weight on the affected side. So this is the antalgic gait. We also have the circumduction. You see the semicircle type of movements. You see this is a normal pattern, but this patient with this type of gaits are going to walk in semicircles just like this. We have the echinovirus, the inversion of the ankles. You can clearly see it on this picture. We have the festination gait in Parkinson's, shuffling gait, taking small steps. This is festination. So we also have foot drop. You can see on this side here the normal, the foot in the normal position, but then in foot drop, the patient is unable to lift the foot due to damage, paralyzed muscles of the dorsiflexors. Genu recurvatum, hyperextension of the knees. You can clearly see, I think you can appreciate it on this picture here. This is the normal stance. This is a normal upright standing position, but the patient with genu recurvatum is going to have hyperextension, going to go a bit more backward from here. We also have the scissoring gait. So you see this patient here, the knees are adducted to each other, so it causes when the patient walks, the the knees come in front of each other, and it's just like scissors, I guess, kind of representation. And then the step edge gait, due to ankle dorsiflexor weakness, the patient compensates by exaggerated hip and knee flexion because they are unable to lift their foot off the ground. So they are going to hyperflex the hip and the knee to try to lift it up. We also have the Trendelenburg gait. So we have on this type of gait pattern, there's a weakness of muscles, hip abductors. So yeah, the patient, instead of like being straight in position, it's always going to bend on the side because the muscles just can't support the patient's weight due to the weakness of these muscles here on the pelvic area. So moving on. Some conditions that contribute to gait disorders, it's usually multifactorial. We have, this list is not comprehensive, just some major ones, including degenerative joint disease, acquired musculoskeletal deformities, intermittent claudication, orthopedic surgery, stroke, postural hypotension, dementia, fear of falling, as well as visual loss. So some classification of gait disorders. We're going to start with the peripheral sensory dysfunction. Peripheral neuropathy or proprioceptive deficit. On physical findings, you're going to notice a loss of touch sense, a loss of position sense as well. And the gait abnormalities, the possible ones here include a steppage gait, as we saw earlier, wide-based, unsteady, uncoordinated, especially without a visual input, may lift feet high and slap on the ground to increase the sensory feedback. We have vestibular disorders as well under this subset. On physical exam, you're going to find a disequilibrium, abnormal Romberg test as well. And great abnormalities here include weaving, drunken gait, type gait, falling to one side. There's visual impairment as well. On exam, you'll find visual loss and then gait abnormalities, tentative, uncertain, uncoordinated gait. So that was peripheral sensory dysfunction. On peripheral motor dysfunction, some examples here include painful or deforming conditions. On physical exam, you can notice pain or decreased motion of the hip, the knee, the spine, signs of arthritis, thoracic kyphosis, decreased lumbar lordosis, and a stooped posture. For gait abnormalities here, you can notice an antalgic gait with shortened stand face on the affected side, Trendelenburg gaits, buckling of painful limb with weight bearing. We can also find here focal myopathic and neuropathic weakness. On physical exam, you can find proximal muscle weakness, distal muscle weakness, exaggerated lumbar lordosis, secondary to pelvic girdle weakness. Here we have Trendelenburg gait, waddling gait, steppage gait with foot drop or foot slap. Postural and locomotor impairments. Some conditions here include cerebellar ataxia. You can notice a poor trunk control, incoordination or other cerebellar signs. Gait abnormalities here include like things that mostly affect the cerebellar area. Of course, we have wide-based gaits with increased trunk sway, irregular stepping, staggering, especially on turns. We have Parkinsonism as well. You will notice rigidity, bradykinesia, tremor, stooped posture. On gait abnormalities, you'll find small shuffling sets, hesitation, destination, propulsion, retropulsion, turning and block, absent arm swing, or freezing of gait. We have hemiplegia or hemiparesis as well. On exam, you're going to find arm and leg weakness, spasticity, echinovarus, genu recurvatum. Gait abnormalities here include leg circumduction, loss of arm swing, foot drag, or scrape. As I'm like calling out these gait abnormalities, I hope we can like all appreciate from the previous pictures I showed earlier on. We have paraplegia or paraparesis. On physical exam, we can find leg weakness or leg spasticity. Gait abnormalities here include bilateral leg circumduction, scraping feet, possibly also scissoring. So the final classification of gait impairments we're going to see is cognitive and white matter disorders. For the condition of disease in this subclass, we have frontal lobe disease, dementia, normal pressure hydrocephalus. On physical examination, you're going to find cognitive impairments, weakness and spasticity, and urinary incontinence. You see, it's just features that are mostly typical of these conditions. On gait abnormalities, we have range of findings which may include difficulty in initiating gait, freezing leg apraxia, shuffling gait, similar to that seen in Parkinson's disease, but with wider base, upright posture, preservation of arm swing. We also have dementia, Alzheimer type or vascular type. On physical findings, we can find mid to late stage dementia, may have fear of falling as well. On gait abnormalities, cautious gait with normal widened base, shortened stride, decreased velocity, and unblocked turning. Key points for gait assessment. We need to have a careful medical history and physical exam for the patient, which can elucidate contributing factors to the gait impairment. Laboratory and diagnostic imaging may be warranted as well, depending on history and physical exam. Use a gait assessment tool like the timed up and go test. Establish a person's comfortable gait speed. Use this both as an assessment and an outcome measure. Remember that most gait disorders are associated with an underlying disease. So a general history and physical exam for a patient presenting with a suspected gait impairment should include evaluation for acute, subacute medical metabolic disease, acute cardiopulmonary disorders, or other acute illnesses. Like we said, it's always secondary to an underlying disease. So you need to have a thorough checkup for the patient. You also need to attempt to identify motion-related factors, e.g. by provoking vestibular or orthostatic responses like the Dix-Hallpike maneuver for vestibular dysfunction. There's also a supine and standing blood pressures to exclude orthostatic hypertension. Vision screening, at least for acuity, is essential. You also need to evaluate the neck, the spine, the extremities, and feet for pain, deformities, and limited range of motion, particularly regarding subtle knee or hip contractures. Measure leg length discrepancies, such as that which occur with hip prosthesis and either as an antecedent or subsequent to lower back pain. You can do this by simply measuring the distance from the anterior superior iliac spine to the medial malleolus. You can also do a formal neurologic assessment, which is critical. Assess the strength and the tone, like we said previously, of the upper and lower extremities, sensation including proprioception, coordination including cerebellar function, station and gait. The Romberg test, it screens for simple postural control and whether the proprioceptive and vestibular systems are functional. Given the importance of cognition as a risk factor, assessing cognitive function is also very important. Laboratory and imaging assessments. You need to do a complete blood count, serum chemistries, as well as other metabolic studies, which may be useful when systemic disease is suspected. Head or spine imaging, including CT, X-ray, MRI, these are not indicated unless the history and physical examination identifies some neurological abnormalities. Performance-based functional assessments, comfortable gait speed and related endurance measures such as a 6-minute walk. These are powerful predictors of falls, disability, hospitalization, institutionalization, and mortality as well. Usual gait speed is tested from a standing start over a distance of 4 meters. A speed of 0.6 meters per second has been proposed as a cut point for this mobility. So, and a speed of greater than 1 to 1.2 is associated with much better functional outcomes and increased life expectancy. So this is what you're going to watch out for when performing your timed up and go test. Be careful about the time the patient executes the test in. So the timed up and go test, Record the time it takes for the patient to rise from a chair, walk 3 meters, and turn and return to sit in the chair. A score of greater than equal to 14 seconds is suggests an indicator of fall risk. A normal score is between 7 and 11, if I'm not mistaken. So if the patient takes this amount of time to complete this task, then they are at much risk of falling. But note that there are some limitations to this test in the presence of cognitive impairments as well as difficulty in completing the test due to maybe immobility, safety concerns, or refusal from the patient. So interventions to reduce gait disorders. Many conditions causing a gait disorder are at best only partially treatable. Other outcomes such as pain reduction may be equally important in justifying treatment. Comorbidity, disease severity, and overall health status tend to strongly influence outcome. Functional improvement becomes the treatment goal, most of the time, for these patients. So, first off, exercise and physical therapy. Knee osteoarthritis, strength, flexibility, exercise, that's aerobic exercise, particularly with a single goal, and when provided at least 3 times per week, shows moderate effects on improving overall function. Post-stroke patients, treadmill training may improve gait speed and walking endurance. Electromechanical and robotic assistance may also increase the likelihood of walking. Parkinson's disease patients, physical therapy, including complementary treatments, yields short-term gains in functional mobility and gait speed. Surgery. For patients with lumbar stenosis, they may have reduced pain after laminectomies and lumbar fusion surgery. However, these treatments can also result However, non-operative treatment, can also result in modest improvements such as walking tolerance. Normal pressure hydrocephalus may have short-term gait improvement after placement of a shunt, but this improvement may not be long-term. Hip knee replacement for osteoarthritis. Pain relief, sizable gains in gait speed, and joint motion occur, although residual walking disability continues. Multidisciplinary rehabilitation, especially after or prior to joint replacement, may have positive effects on these patients. Mobility aids, we have lift, internal or external lift that correct limb length inequality. It's used in a conservative, gradually progressive manner. Ankle braces, shoe inserts, shoe bodies, and sole modifications as well may be used. Walking shoes with low heels, relatively thin firm soles, and if feasible, high fixed heel collar support as well may be helpful. So take home message from this talk today, we need to understand that gait disorders are common in older adults and they're a predictor of functional decline. The cause of gait impairment in older adults is usually multifactorial. Therefore, a full assessment must include consideration of a number of different causes as determined from a detailed physical examination and functional performance evaluation. Those two are very important. Various interventions ranging from medical to surgical to exercise, they can all reduce the degree of impairment, although some residual impairment is often present. So a final case to close off our talk on gait impairment for today. A 78-year-old man, he comes to the office accompanied by his daughter, who is concerned about his frequent falls. She says that he tends to fall when he is away from home. He does not fall often in his house. The patient is unconcerned about the falls. On physical exam, the blood pressure and heart rate are normal, including postural responses. Visual, vestibular, and peripheral sensations are all normal. Muscle strength, motion, and endurance are normal as well. There is no rigidity or abnormal resistance to passive motion of the joints. Gait speed is 1.18 meters per second. He steps with no difficulty over an obstacle placed in his path. With a few small steps on approach, he does not make appropriate adjustments to maneuver past furniture in the exam room or past other people in the hallway. Which of the following is most likely to be a factor in his falls? cognitive dysfunction, cerebellar disorder, Parkinson's disease, or Parkinsonian syndrome, spinal stenosis. You guys can just put the answer you think is right in the chat box. I can't have access to it right now, but yeah, you can just put out your answer now and we can all go through which one is the correct one. So the answer key for this question is cognitive dysfunction. This patient has difficulties related to motor planning. He does not navigate around furniture or adapt to changing conditions in the environment, e.g. along others along his path. His inability to adapt or adjust his movements as needed suggests that cognitive dysfunction may be a factor to his falls. That he is more likely to fall away from his home in less familiar places, and his lack of concern about the falls are common features of a mild cognitive impairment that contribute to his fall. He has little insight to his cognitive difficulties, and thus he walks freely, he falls frequently, and yet he remains unafraid of falling again. This patient has no deficits in muscle, motion, or endurance in relation to walking, so a problem of cerebellar origin is unlikely, given normal findings on sensory exam and his postural responses to perturbation. The lack of sensory changes as well, muscle strength deficits, and pain or altered posture, that is fall, flex, drunk, argue against spinal stenosis as a contributing factor to the frequent falls. So a final conclusion for this, walking is complex. Multiple limbs move in different directions while the body progresses forward in the direction of intent, using a rhythmic pattern of stepping integrated with posture of the trunk and various phases of gait, all of which happen in an environment that may include changing conditions and barriers. These factors of motor control include muscle actions in walking, use of energy for walking, force to propel the body, stability and maneuvering, neural control to use movement-related feedback and to integrate components, and environmental challenges as well. It all requires appropriate gait adjustment while the walker remains mindful of his or her intent. Most of these factors occur without the person's direct focus. Gait changes, speed, step width abnormalities, stance time variability, and cadence are all associated with risk of falls and mobility-related disabilities. Gait and cognitive problems are independently associated with an increased risk of fall for older adults. So, especially cognition, we should be very attentive to the patient's specific features when examining them, because anything could be contributing to their impairment. That's why we keep insisting on the fact that a thorough physical exam, a thorough examination of the patient's gaits are all important in elucidating the specific etiology of each patient's impairment of gait. So yes, that is going to be the end of my presentation. Thank you. Any questions or any comments are welcome.
Thank you so much for this great presentation, Dr. Mylene. Any questions or any comments? I think it's an important topic and we should pay attention to, as she mentioned, the multifactorial impact of this abnormality. So thank you.
Thank you, Dr. Nadir. Thank you.
Thank you, Dr. Mylene, for the great presentation. Really appreciate that. Now, if no one has a question, we can move to the next topic. So Dr. Raghad will be talking about how to write a winning abstract, and then I will be completing this topic by talking about how to present a winning abstract. Okay, Dr. Raghad, we can see the screen, thank you, but we cannot hear you.
Okay, good evening, everyone. Can you hear me?
Yes, we can hear you now.
Okay, so assalamu alaikum wa rahmatullah. My name is Raghad Asim, and I'll be speaking a few words on crafting a winning abstract. طيب, before we start, I'm sure everyone here has spent hours or even weeks on a piece of work and they've struggled to explain it in just a few sentences. And that's basically what writing an abstract is, or what it feels like. So today we're going to be talking about how to take a research idea that you have, turn it into a very strong abstract, and even get it accepted at conferences if possible. And a lot of people think abstracts are just some boring requirements at the end of every project, but they're actually one of the most important parts of the whole research process. Yani. So hopefully by the end of this presentation, you'll be able to see things a bit differently. So why your abstract matters. So what is an abstract? An abstract is a short, standalone document that concisely summarizes your work that you wish to present. I think that many people underestimate abstracts, and put yourself in a reviewer point of view, and that you have to review almost 100 abstracts that you have to read, and you'd probably be tired, and you've got deadlines, and you have to make it in such a short, like you have to make decisions in such a short amount of time. So are you going to be spending 10 minutes on every abstract? Probably not. So you're going to have to decide within seconds if something seems interesting to you or not. And that's why a strong abstract usually make poor or average abstracts look really good, whereas weak abstracts can hide the fact that you put in effort and really good work into your research. So this is why an abstract is very important. And you know how we say don't judge a book by its cover? That's kind of the opposite of what we usually do with abstracts. It's not ideal, but it's the reality. Yani. So starting off with the idea, before writing anything, we need a good idea. And this is where like most of the hard work happens. A lot of people focus so much on the writing that they tend to forget about how important it is to focus on a strong and start off on a strong, focused idea, because it then makes everything easier when you have a clear idea as to what you want to do exactly with your research. So think of it like you're building a house. So the foundation needs to be very well established, because if your foundation is shaky, then it doesn't matter how nice your walls are. So before we even start talking about the sentences and the word counts, let's have a look at how research ideas develop. So from curiosity to a research question. I feel like this is everyone's favorite part of the process because it's very practical. Most researchers don't start with some genius idea. It's usually some confusion that people have. You read something and you think, this doesn't answer my question. Like, has anyone ever answered this question before? So this is where it stems from. Or maybe you read one study and you read another study and you think, no, they're disagreeing with each other. So here's where my input can go, or here's where my contribution can stem from. So let's put it this way. You think of a topic like social media, for example, and then you move from a topic to a specific question. So you think social media can't be a research question. So instead you put it as, how does social media affect sleep quality, for example? It's a very famous topic that most students do. So how does social media usually affect sleep quality among university students, for example? That's how you turn it into a research question. And some people usually say that a good test is if you ask somebody, if somebody asks you what your research is about, and you can explain it in one sentence, then it's probably not a good, it needs more refining. So you observe a gap or a problem, and you quickly do a literature scan, you narrow it down, and you write it in one sentence, and you check it against reality. Okay, so who are we writing this for? One mistake that most people do is writing for themselves instead of the audience. think about it like speaking to different people. You wouldn't explain football, for example, to a professional coach the same way you would explain it to someone that's never watched a game in their life. And research is exactly the same. You'll have conference reviewers, you'll have panels, journal editors, and they're all looking for slightly different things. So before writing your abstract, ask yourself who will actually be reading this. That question alone can improve your abstract a lot. Okay, so the structure of a strong abstract. Now we're going to get into the actual structure of how to write an abstract, and I think this is the part that people expect or when they hear the word abstract writing. And most strong abstracts follow very similar pattern. There's a structure, there's a proper structure behind it, and once you understand that structure, the writing becomes a lot easier. So there's 5 elements every abstract needs. If you're going to walk out today with one thing from my presentation and you're going to remember one thing, I would rather it be this slide. I think it's one of the most important things. Every good abstract that you've read has these 5 elements. The 5 elements are background, the gap, objective, methodology, results, and its impact. So think of them as answers to 5 simple questions. So for example, with background, think of it as, why does this matter? You're giving them a quick background as to what the subject of your topic is, and you're doing that, but you're also giving them the broader context of why does it matter in this world today. And then number 2, with the gap, think of it as what's missing. So it's the justification of your study. Is there a gap? If there is, address the gap. This is exactly what's intended. Number 3, which is the objective, think of it as, what did you want to do aslan with this research? So did you set out to do did you set out to do one clear objective? If so, write it in a direct sentence. Number 4, with the method, how did you do it? So what did you use for your design or for your sample, your data sets? Where did you save them? If you used any applications, make sure to mention them. Any applications that helped you with storage of data or manipulation of data. This is where you usually mention stuff like this. And number 5, the results and impact. What did you find? Think of it as, what did you find from your study? Give us numbers. I think numbers 100% beat generalities all the time. So be very specific, give us statistics, and yeah. If one of those answers is missing, the abstract feels incomplete, and a lot of rejections happen because they fail to mention at least one of these 5 elements. So whenever you're reviewing your work, make sure to use these 5 elements in your abstract. So writing the background and the gap, it's the opening, and the opening matters a lot. So think of it like you're in a movie, for example. When you're watching movies, the first few minutes of the movie it's your deciding factor, whether you're interested enough to keep watching or khalas, you've had enough and like this is where you stop. And abstracts work in the exact same way. Instead of starting with this paper investigates, try starting with what the actual problem even is. So make the reader care, and then make sure to identify the gap along with it clearly. And don't make the reviewers play detective and like make it hard for them to find out what your research background even is about, and have them figure out what's missing. So writing methods and results and the impact. This is where many people either write too much or too little. So for the methods section, reviewers don't need your entire research paper. All they need is just enough information and the right information to trust your work. So state your study design clearly and mention the same size and save the heavy details for the inside of the paper. Yeah, just that's enough. And for the results, the specifics are very powerful, And as I said earlier, statistics and numbers are even more powerful, so make sure to mention them. If you have them, use them. And then don't forget the impact. Think of it like this: if you have any interesting finding, why should anyone care? That's the question that you need to answer exactly with your impact. And that's how you come up with a powerful impact. Like, how will this specific thing change your practice in a hospital setting, for instance? So the types of abstract, I won't get into so much detail about this, but something that surprises people is that not all abstracts are the same. Different fields use different abstracts and different formats of the abstract. If you're in health science, for example, you'll often see structured abstracts. That's the one that we use. In humanities, for instance, unstructured abstracts are more prevalent. And then there are extended abstracts, graphical abstracts, and a lot others. But the key is always read the submission guidelines. So you don't want a good abstract to get rejected just because you use the wrong format. That's just a waste. And that's a very, like, you'd be surprised, but that's a fairly common reason for rejection of most works. Your work might be okay, but you just didn't follow through with the guidelines. So revising until it's right. Nobody writes a perfect abstract from the first attempt. And good abstracts are rewritten many times. So if you feel like your draft is a bit messy or you're not completely sure about your work, revise it and make sure to understand first that this is completely normal. Writing is a really extensive process, and it's all about improving. Nobody creates perfection immediately. A practical revision approach. Okay, so there's a 5-pass approach because it gives you a complete system. Instead of just staring at your abstract and hoping that it improves, focus on one thing at a time. For example, first check its completeness. Is every element present? And then check for the clarity. Can someone outside of your field, not in your specialty, understand every sentence? And then check for the flow. Sorry, I missed one. Check for the precision. Is every wording pulling its weight? And then you check for the flow. Does it read as one coherent story? Is everything connected to each other? Is it giving you the complete story? And then finally, your word count. Are you within a limit or not? Check that first. If you are, make sure to not include anything that's unnecessary, and vice versa. So it's much easier than trying to fix everything all together if you just take it one step at a time. And definitely get another person to read it, because fresh eyes notice things that you've become blind to. Okay, so common reasons abstracts get rejected. This slide is basically just a list of avoidable mistakes. So most of them can be fixed, and most of them have a lot to do with vague objectives. You're not very specific about why you're investigating things, and so missing results, for instance, too much jargon or weak openings and weak backgrounds. Reviewers often reject abstracts not because the research is bad, but because the writing does not communicate it well. And that's why strong communication skills are very valuable in research. Keywords and making your work findable. So let's talk about something most people overlook. So keywords. Keywords are not just boxes that you fill up quickly before submitting. No, think of it as a search button online, because keywords is what helps people online find your work, and research does the same. When it comes to looking for papers, your keywords have to make sense and they have to coherently tie with your whole paper. So when you choose keywords, make sure you choose good keywords, not just any keywords. It makes your research more visible. And why does visibility matter? Because because to be able to find the research, you have to make an impact, and the only way you can do so is if you have good keywords. Submitting to conferences. So, okay, so now that you've written your abstract, your next challenging part is to figure out where to send it. Not all conferences are right fits for every paper. Sometimes people target the most international and the most famous conferences and immediately get discouraged when they're rejected. So making sure to choosing the right conference is very important and is actually a strategy. So again, I'll just quickly brush into this and won't go into much detail, but different conferences serve different purposes, and some are extremely competitive, others are not very. So the ones that are not very competitive usually focus on networking and stuff. So for early career researchers, there's nothing wrong with starting at your local conferences or even regional ones or any events. Matter of fact, they often provide even better feedback one-on-one directly for you, and even more opportunities for you to talk to people directly and basically find your right audience. A sensible submission timeline. One thing I learned is that deadlines arrive a lot faster than you expect. So conference submissions can become very stressful if left till the very last second. So you have to plan ahead. Planning ahead gives you time for revisions, for you to avoid any unexpected problems, or so just a basic scheme for 3 to 4 months before. Identify your target conferences that fit your topic. 6 to 8 weeks before, you have to already have drafted your abstract, tailored the language the language. 2 to 3 weeks before, you have to have the final revision pass, read it out loud to check the flow, see if it fits all the requirements, and make sure to submit it early. After submission, record what you've submitted and which version, if rejected. Request feedback wherever available, and revise and submit your next target. Okay. So before you hit submit, there's a very quick checklist that we call a final safety checklist. It's like a pilot checking his aircraft before takeoff. You've already done all the hard work, and now you're just making sure that nothing is missed. So make sure all 5 elements are present. The opening sentences are compelling, no unexplained jargon, specific findings are all mentioned, and that active voice is to be used throughout. Make sure you hit your word count or within the limit, not over it. Format matches what is required, and at least one other person has read it and given you his complete, honest feedback. Make sure that you've read it out loud at least once to check the flow, and submit it at least 24 to 48 hours before your deadline. So presenting at conferences, imagine that the best case scenario, your abstract gets accepted. So after that comes presenting, and a great abstract gets you in rooms, but a great presentation is what helps you get to people, and it's what helps you be remembered, and for people to even remember you even after you leave the room. So I won't get into this at all, actually, because this is Ayah's presentation, and she'll be getting into it into more detail, and she'll be taking us through it, inshallah, later. So just a quick summary to wrap everything up. Strong abstracts begin with strong questions. Every abstract should include the key elements we've discussed today. Always know your audience. Revise. Choose conferences strategically, and when your work gets accepted, prepare your presentation just as carefully as you've prepared your abstract. I'm gonna conclude by saying this one thought. An abstract is the first impression people have of your research before they meet you, before they read your paper, before they even hear your presentation, they meet your abstract. So yeah, thank you very much. If anyone has any questions?
Thank you so much, Dr. Rock. Excellent, wonderful presentation.
Thank you so
If no-
much, Dr. Raghad.
Thank
This
you.
was a really good presentation, and I hope everyone now knows how to write a successful abstract. And I hope after this presentation, all of our abstracts that we're currently working on get accepted. Thank you, really appreciate it.
Thank you,
If no one has, okay.
Dr. Nadir, thank you very much. Actually, Ayah, I felt very relatable to this because we're going through the exact same thing at the moment, currently, the two of us, and the rest of our team. So it just kind of made sense. And I'm glad that you'll be taking over and completing us till the very end with having your abstract or presenting it at conferences. And thank you very much, Dr. Nadir. And Ayah, you can take over.
Thank you.
Thank you. So since no one has a question, I'm going to share my screen now with you guys. Okay, I hope my screen is clear for you guys and you can hear me clearly. Okay.
Yes.
Okay, thank you. So now Dr. Raghad has talked about how to write a successful abstract, and now I'm going to talk to you guys about how to present a successful abstract. At first, I would like to thank you all for attending, and I would like to thank Dr. Nadi for this opportunity. So to start with, why presenting at a conference? Why would we want to present our abstract at a conference? I mean, why this is an important thing. Okay, so conference presentations are more than requirement for academic advancement. They provide a platform to share your knowledge and gain feedback from experts and increase visibility within your field. Okay, so presenting at a conference can open doors to collaborations, to funding, to opportunities, and it's also a massive chance for a career development. Okay, this is why it's very important, it's very crucial, and I encourage every single one of you guys to at least participate in one or two presentations in the future. Right, so how to benefit from this presentation? Okay, so when you go into a conference, okay, try to benefit as much as you can. Okay, so you can show your work before publication and then receive a constructive criticism, which is a really good thing that helps you to grow and develop in the future. And then you can also learn about current developments from other people's abstracts and from other people's presentations, from the discussions, from the workshops that are going on and the sessions within this conference. Okay, these benefits can significantly contribute to both personal and institutional success. Okay. Okay, so now Dr. Raghad has talked about the abstract itself and writing an abstract. I'm going to just go quickly through that. So the strong abstract that we're looking for is a clear, concise, and informative one. It should explain why this work is important, why this topic is important for us now, and what did we do to write this abstract, which is the methodology section, what was found, which is the result section, and then why these findings matter. This is the most important thing that the reviewers and other attendees at the conference are taking care of. Like, they only care about why is it important, why these findings matter. Okay. So just try as much as you can to make your abstract follow a logical structure. As Dr. Raghad mentioned, start with a brief background about the topic and state the objective. In my point of view, the title and objectives are the most important parts of the abstract writing and abstract presentation as well. Because the title is the catching part, and then the objective is what keeps them listening until the end. The objective is the main agenda that you're going to talk about. Okay, so following this structure will help the reviewers to quickly understand your work. Okay, so hopefully after your abstract is accepted, okay, and now you're trying to prepare for your presentation. So for those who don't know, presenting in a conference could be an oral presentation with slides, or it can be a poster presentation, like you're going to present from a poster that you already prepared. It can be an online presentation as well. So it depends on the type of presentation that you're participating with. But in the end, all of these types of presentation needs preparation. Okay, so when it comes to oral presentation with slides, try to make your slides outstanding. Don't try to make them good. Don't try to make them excellent. Try to make them outstanding as much as the best as you can. Try to use minimal text and more visuals, because this is what can help people to understand more and easily about your topic. Okay, and each slide should communicate one key idea to avoid overwhelming to the audience. Okay, so sometimes when you listen to other people's presentations, you feel overwhelmed, like, what are we talking about? What's the main point here? You get lost in the middle. We're trying our best to avoid this. Try your best to make it simple idea, a key important thing that you're talking about in every slide. Okay? And when it comes to presentation, just try to make it as a storytelling. Just tell a story. So the story starts with, for example, we found a problem, and then this problem has a significant impact in our healthcare system. And then we came up with an idea of how to solve this problem. And then we made this title, and then we made this objective. And then following this methodology, we came up with these results. And then this is the conclusion. So it's just like a storytelling. Let me give you an example of an abstract that I have personally presented a month ago in the Royal College of Physicians. So we've noticed that there is an increasing number of hospital readmissions, okay, during the first 30 days of discharge, especially in elderly patients. So this was the problem. So we came up with an idea of investigating how to reduce 30 days hospital readmission, okay, from skilled nursing facilities. So this was the idea. And then why is it important? Because hospital readmission places a significant burden on the healthcare system and the patients themselves, and it costs a lot. So this is why it's important. And then I started to talk about the methodology and then the findings. So just try to make it like a story, okay? This would make it very easy for the listener to understand what are we talking about. So yeah, we were gonna go through the structured abstract that we already wrote, but just try to tell it as a story, okay? This will help the audience to remember your message and stay engaged. So at first, when you start to present, try to smile, okay? Then this smile will give this sense of confidence, okay, to the audience, and it tells them that this person knows what he's doing. He knows what he's going to talk about. So trust me, do not underestimate the power of smile. It's really powerful. And then introduce yourself, okay? And then say a small friendly phrase like, nice to meet you, thank you for attending, any small friendly phrase. This is just to break the ice and make the air very easy and comfortable. Now go directly to your abstracts. For those who don't know, when it comes to presenting in a conference, you usually have a time limit. So we don't want to waste our time in the introduction, although it's crucial, it's important. Just make it very concise and easy and friendly, and then go straight forward to your abstract. So the title is often the first thing that people read. A good title should be specific, concise, and engaging. Okay, and it should accurately present the content while attracting the attention of conference attendees and reviewers. Okay, so first, smile, introduce yourself, say a friendly phrase, and then state the title out loud. Try to be as loud as you can. Now, confidence comes from preparation. So if you can prepare multiple times, and then when you go to the conference, maintain eye contact and speak clearly, as clear as you can. In the end of your presentation, say, do we have any question? And after answering these questions, thank them for listening. I know these are very simple phrases or simple sentences that you can say, but they can make a massive change. Okay, so just try to be friendly and welcoming as you can. So prepare your presentation and then practice with your colleague, with your supervisor, whichever you find available. Keep in mind your time management. So, for example, in my presentation, I had only 3 minutes to convince the judges. I had only 3 minutes. Can you even imagine? So I was practicing. I started with 7 minutes, down to 5 minutes, and then finally I concluded with 3 minutes successfully. And that was with only practice. Do not read every single sentence from your poster, and try to speak from your mind as much as you can. So there are some people who are just reading the poster. This is not the idea. This is not the concept. And this is not the purpose of presentation. Just try to speak from your mind. This will give them the sense of your confidence and you know the topic that you're talking about. So what will happen if we had any question? Okay. So you will definitely receive questions. If you didn't, that's not a good sign. Because if people understood and actually know what you were talking about, then they definitely will have a question for you. Okay, so whenever you have a question, this is a good sign. That means you're doing great. Okay, these questions is an opportunity to demonstrate your experience and engage with discussion. So listen carefully to the question, try to understand what they're talking about, and then answer directly. Okay. To help you to manage questions, especially those difficult ones, read about the topic first. Try to read about the topic that you're going to talk about. And then if you have any specialist in that topic, just discuss this abstract with them before going to the conference. This will help you to navigate through any difficult question that you have. Sometimes we might receive questions that we don't know the answer. That's absolutely fine, guys. We are learning. We're still learning at this stage. So we're not expected to know everything. No one knows everything. So don't worry about questions that you don't know the answer. Okay? If you don't know the answer, just acknowledge it. Say with very complete honesty that you actually are not aware of the answer at this moment, but we can discuss this in the future. That's it. That's absolutely fine, guys. Don't worry about questions that you don't know about, but try your best to read more about the topic. Try your best to answer as much as you can. Okay? If you receive the constructive feedback, this is really good. So some people take it as a bad sign, which is completely the opposite. This is a really good sign that your poster is actually good. And these people are trying to guide you to the right way in the future. Okay? Just always remember that we're still learning. I just wanted to share this slide with you guys that following all these steps that I've just mentioned to you, And with the guidance of course, Dr. Nadir, with his support, and with my colleagues that I prepared and practiced with, we won the best poster presentation in health services and sustainability policy and workforce development category in the Royal College of Physicians annual conference in May 2026. Sarah. And from this, I would like to thank all the team colleagues that we all worked hard to publish our abstract and present it the best way possible. So thank you very much, everyone in my team. Now, after we presented our abstract or your poster, your presentation, what will happen next? This is not the end of the conference, of course, guys. We still have so much opportunities. Okay, you have these chances to network with the people and participate in conversations. There is going to be just a friendly conversation during breaks, during sessions, and social events and workshops. So just try to participate in them as much as you can. This will help you for future opportunities. Okay? And this is a picture of me with the president of the Royal College of Physicians and the head of quality improvement in the Royal College of Physicians, which I just met them in the conference. We will just, there was just this part which we had this walk and talk session with the president. So we were just walking. That was in London. So there was a Regent's Park right in front of the building of the Royal College of Physicians. So we were walking around, talking about any topic, like random topics. Literally, we were talking about this park, and we were talking about Queen Elizabeth. We were talking about different topics generally in life, not necessarily something scientific. And then this is how you build a good network with these people. They were very friendly, and as you can see, smiling in this picture. So just to conclude that the conference is not all about abstract presentation. There are so many opportunities that you can benefit from. And this is us, my colleague and I were discussing our abstract with another abstract presenter at the conference. Okay, so to conclude, a successful conference participation involves more than presenting research. Write a strong abstract, create effective slides, communicate confidently, build meaningful professional relationships, and embrace teamwork. These skills will help you to make a lasting impact at any conference. Thank you very much, everyone, for listening. If anyone have any question, please feel free.
Thank you both for great presentation. Thank you for sharing your experience as well. Yeah, I agree. The conference, there are different aspects, and you can meet people. You can know about the city, if it's a new city for you, and many more things that you can enjoy or you can learn, as Dr. I mentioned. Thanks for sharing and great presentations. Any questions?
Yeah, I do have a question, actually. I was actually initially going to shoot this towards Dr. Nader, but it seems like Dr. Ayah also knows, and Dr. Raghad. So in regards, I'm also going to make this a project update so that we can save the time. On behalf of our abstract, Dr. Noon did actually accept to present it in Michigan. And I just wanted to ask a question, because I've seen Dr. Ala and Dr. Almar also present both of their abstract, which they already have a poster. I'm pretty sure what Dr. Ayah had presented in the conference was a poster. I'm not sure if she also did a presentation. So is it required to do both? Is it and or is it just or? Like it's either you take one or yeah, so that I can tell my team as well. Because right now we're in the poster making phase of the work.
It depends on the conference that you're participating in. So our conference, the Royal College of Physicians, we only had two options, either poster or online presentation. We didn't have an option of oral presentation with slides, but there are so many conferences that you get to choose either or
Yeah.
both. So it depends.
Thank you so much. Thank you. Like, sorry, I have Alzheimer's, so I have to ask the next question rapidly. I'm kidding. Anyways, yeah, I forgot the question. Anyways, yeah, I forgot the question. But
No,
thank you so much, and
still-
thank you for your beautiful presentation.
And can you just clarify for Dr. Hussain? When you submit your abstract, some of the conferences will ask you, is it a poster or would like it to be an oral presentation? Because sometimes they may upgrade you if it's an important topic from a poster to oral presentation. But most of the time it's either or, like either you go for a poster and it's gonna be like either virtual, you do it like what we are doing now, or you go in person and then you have the poster held in the wall and then you are presenting to the people who are coming to see your poster, including the judges. Sometimes they can invite you from the start. When they accept your presentation, they can say, we accepted it as a poster and you're all set. Or sometimes they say, we accepted it as an oral presentation.
All right, thank you so much. Because I've seen the steps, because I was talking to Dr. Almar, and she showed me the steps of the registration in regards to Royal College presentation. It was much more like organized. In behalf of the Michigan University, it was way chiller. Like even they said it on their page, is that it's going to be chill, no stress kind of conference, and in which like we get to talk about like posters and like anything new. So it was more on that. So even then, like they even said, oh, you can just email us the abstract, we'll see if we approve it or not. So it was much more like and I know that Royal College, like as far as Dr. Almar mentioned, is that they also shared like contributions, like a fee required to post, and Michigan was they didn't have the same like metric, like they didn't, it was free of charge, and yeah, so that's why I had to ask, like, because I'm not entirely sure. So yeah, thank you so much for everyone's advice.
Thank you all. If no more questions, we can move on to the next topic.
Okay, thank you everyone for listening. And if you have any question, you can contact me at any time. Don't worry about that. Now we will need to move to the next topic. Dr. Nabiha will be talking to you about her topic. Are we ready?
Yes, we are ready. Just a minute, I just need to open my presentation. So today, my topic would be reference styling in journals. And we are going to do an overview of the major styling styles. So first of all, we need to see the objectives. So our objectives would be to understand the purpose of citation and referencing, differentiate between major citation styles, and then recognizing the in-text citation formats and identifying the reference list structures. So why is it important to cite the resources? Number one is to give credit to the original authors, and then we need to avoid the plagiarism, and we have to uphold to the ethical standards in the academic work. We need to strengthen our credibility of our work and the research, and then it is important to strengthen the scientific arguments by providing evidence and backing the claims, allowing readers to verify the sources where we have taken our evidence from, and enabling a deeper exploration and validation. and then demonstrating the evidence-based knowledge, which is the most important thing when we talk about the academic work and academic research. So there are two major citation systems. Number one is the author date system, and the other is the numeric system. With the author date system, it is mostly the author's surname and the publication year, which is more focused to, and it is done in APA, Harvard, and Chicago styles, while the numeric system is mostly used in the Vancouver, IEEE, and AMS styles. So first of all, let's talk about the APA style. It is most commonly used in psychology, education, business, and social sciences. When we talk about the in-text citation, it's normally the last name of the author and then the year of the publication. And when the reference example is given towards the end, it's normally the last name and then the initial of the first name, then the year, and then we mention the title and the publisher. This is the general format of the APA style. So it's 12 pt time new Roman or 11 size calibri, a double spacing throughout the document, title, page, and structured heading is often required. And then it is almost always arranged in the alphabetical order. And the alphabetical order is according to the last name of the author. Then we come to the MLA style, that is the Modern Language Association. And as seen by the title, it is mostly used in literature, humanities, and arts. And the in-text citations are normally the last name and then the page number, and there's no comma in between. And when we mention the cited example, normally towards the end or towards the start of the of our work, it is the last name, comma, the first name, and then it is the title of the publication, and then the publisher, and then we come to the year. So the formatting again is it's the 12 size time new Roman or double spacing is done. Usually no separate title page, header and with surname and page number, as we said, is used in the in-text citation. Work cited page for all sources. Work cited list is always arranged in the alphabetical order, and again the alphabetical order is according to the surname of the author. Then we come to the Chicago style. So it is widely used in history, fine arts, and publishing. It allows detailed citation. For example, here we can see it's an important thing in the Chicago style is that it is mentioned in the footnotes. So here, as we can see, it's the complete first name, John Smith, and then it is the article or the title, and then the page number. And then towards the end, there is a separate bibliography which provides full source details, as we can see here. In text, it's the first name and then the surname, but in the bibliography, it is the surname, comma, the first name, and then it is the title, and then the publisher, and then the year. And again, title pages require double spacing is done, utilizes the footnotes or endnotes for the citation. And when we talk about this, it is in the in-text citation. And then there's a bibliography page towards the end. And bibliographies are arranged in the alphabetical order according to the first author's surname. Then we come to the Harvard style citations. It is common in business, economics, and sciences. In-text citations are last name, then comma, year, then comma, page 45. So P.45. It allows for a quick source identification using the author date system. So here we can see the surname of the author and then the year of publication. Reference example, as we can see here. So here it is the surname, comma, the initial of the first name, dot, comma, then the year. Then we come to the title, business research, then the publisher. So it is quite similar to the APA style of citation. Double spacing is often required. Reference list is again by the alphabetical order according to the author's surname. And institution-specific variations are quite common with the Harvard-style citations. Then IEEE, so it is Institute of Electric and Electronic Engineers, as quite visible from the name. It is used in the engineering, computer sciences, and information technology. In text citations are numeric, so like this, the one that is written, linking directly to the sequential reference list. So in the reference, there is first name, initial of the first name, for example, J dot, and then the last name, comma, computer system, that is the title, and then we come to the year. Numbered reference are more core component. Reference lists are listed by the order of appearance in the text and not alphabetically, and does not use author date system for in-text citation. Then we come to the Vancouver style, and this is the style of citation commonly used in the medical writings. So, a compact numbered reference, it is used in medicine, health sciences, biomedical research. Here, if we see, this is how normally it is written in the in text, or in the form of the superscript, and then it is referenced to the final reference list. And here, as we can see, it is the last name, then the initial of the first name, dot medical research basics. That is the title, and then the publication year. So uses numbered reference throughout the text. References are listed sequentially based on the order of citation and widely adopted by the medical journals for its clarity and conciseness. So PubMed index journals. So PubMed index journals normally use Vancouver or National Library of Medicine based citation formats. This involves, as we have seen, numeric index citations. And why do we use it? Because it facilitates rapid identification of the sources in the medical literature. This is the key characteristics of the major citation styles. For example, APA, we can see last name and year, and towards the end, it is always the alphabetical order, normally used in the social sciences. Then MLA, it is last name and then the page number. In the in-text citation, towards the end, it is always the alphabetical reference order list and normally used in the humanities studies. Then a Chicago style, normally in the footnotes, in the in-text citation, alphabetical reference order list, and normally used in the subjects like history. Harvard, it is the last name, then the year, then the page number. In the in-text citations, always in the alphabetical order and normally used in the business sciences academic work. IEEE is normally used in engineering. In-text is normally always a numeric identifier, and then the order of appearance is in accordance with the order it is mentioned in the text. And then Vancouver, again, it is either the numeric value or the superscript. And then the order of appearance is how it is also mentioned in the reference list and normally used in the medical studies. This is again a journal review of how the different citation styles are mentioned in the in-text citations. We have already talked about it. So these are different softwares which can help us with the reference management. There is Zotero, which help us collect, organize, cite, and share the research. Then the EndNote, it is very helpful in managing the bibliographies, references, citations. Mendeley, then the benefits again is that there's automatic citation generation, less time consuming, journal specific formatting can be done, and then it reduces the errors that can be made if we do all the citation manually, and again it increases the efficiency. Key takeaways from today's presentation is to identify the different disciplines utilize distinct citation styles. Author date and numeric systems are two primary citation tools. APA style is dominant in the social sciences and education. MLA style is the standard in the humanities and literature. IEEE is mostly in engineering, while Vancouver is crucial for medicine. Always adhere to the specific author guidelines to your target journal. This is very important. These are the references that are used, and that's about it. Thank you so much.
Thank you so much, Dr. Nabiha, for great presentation and important topic. I think we need to know about that. So thank you for sharing. Any
Thank you so much,
questions?
Dr. Nader.
If no more questions, we can move on to the last, I think, topic, and it's the update, if I'm not mistaken. So we have two abstracts there that were submitted and accepted to the conference in University of Michigan here in Michigan, and that would be in August. So congratulations to both teams. And I think the next step is to work on getting this abstract as posters. So if you need help, let me know. And if any of the team members is here, can you share with us if you have any comments or next step? I know Lujin mentioned that Dr. Noon accepted that she will be presenting one of the posters, or any additional information you want to share, please go ahead. Dr. Ayah, did you figure out who will be presenting?
Yes, we managed to find someone from the team itself. She lives in a different city, but she said that she will travel to to Tennessee to present for both teams. So the contacts that you sent me. It's
going to be in Michigan, right? It's going to be in Michigan.
So our abstracts are different from Dr. Lejane's abstracts. Our abstracts were the American Society of Gastroenterology. We had two topics. Yeah, it's okay.
Okay, go ahead then.
Yeah, and well, I mean, we just submitted last week, and we're waiting for acceptance. So let's hope and pray that we get accepted, hopefully. And thank you very much for sharing this contact information with people who are living in that city. I will definitely contact them when we get accepted to see if they're available to present for us. Thank you.
Thank you so much, Dr. Ayah, and sorry about the confusion.
Yeah, it's okay. It's okay.
Any other updates, any other questions, or thing that you want to share? If not, I'd like to, someone is, okay, Dr. Malas, please go ahead.
Hello, Dr. Nadir. Hope you are doing well. Hello, everyone. Hope you are doing well. Actually, for another project, Dr. Ayah found someone, I think Dr. Khalid, live in Michigan. We're gonna present it.
Okay.
Yeah.
Excellent.
So, yeah. So, inshallah, we're gonna complete the registration for him and so on, and then we're gonna go ahead with poster.
Sounds good. Appreciate. Thank you so much for the update.
Thank you.
If no more questions, yeah, go ahead.
Can I ask out of interest? Can I ask out of interest, like, what's the topic about? And yeah, if you guys don't bother like sharing.
I think there are two abstracts there were submitted to University of Michigan here in Michigan, and I believe both were accepted. Anyone wants to add information, please feel free.
Hi, Dr. Nadir. Are you talking about sharing our abstract, like what we submitted for University of Michigan? Like,
Yeah,
do you
just
mean we should share?
yeah, she was asking about what the topic about.
Oh,
Maybe the
no.
title is the
Dr.
idea.
Lujen and I worked at, I don't know, are you talking about gastroenterology, Dr. Lujen? Which one are you talking about?
No,
Okay.
ours is no-see plastic pain. Like apparently there are other more. So like this broadens the scope for like presenters, and that's why I had asked like, oh, there's like a big scope of people who are also like able to present from there, you know?
Oh, okay. I
I
only know
wasn't.
about the icon one. I don't
Yeah,
know about.
yeah, that's the thing. Like I wasn't aware that like University of Michigan was actually doing like multiple ones. So that's actually really interesting to hear.
Yeah, quite interesting.
Is it also on August, Dr. Nader?
So the icon is the deadline was June 1st, and the presentation will be in August 4th or 5th. Uh, Maybe Dr. Ayah can elaborate on the GI conference, if you don't mind.
Yeah, so we had two abstracts that were submitted to the American Conference of Gastroenterology in Tennessee. The deadline was in the 1st of June, and we still didn't receive the acceptance or rejection for that. But both of them were scoping reviews. They were not systematic review because when we started to work on this project, we only had like 10 days to submit, and we worked really hard. Like we had more than 20 people in our Forest Green 3 team. So we were divided into two separate groups. Each group were working about on a different abstract. So the first one was about environmental factors, and gut microbiome alternations appeared to be associated with the development of early onset colorectal cancer. This is a scoping review. Okay, if you bear with me for a second to tell you the second title. Sorry, guys. I keep forgetting. It was very hectic week. I was working on both groups, here and then, and I was the team leader for both groups. That was crazy. But thankfully, we managed to submit in time. The second one was talking about machine learning models and artificial intelligence tool for the early detection of colorectal cancer. This is also a scoping review of clinical performance and implementation feasibility. And I think the conference itself would be carried on in October. It's not in August. And that's the difference between this one and the Michigan one, probably.
That's great. Yeah. Thank you for sharing and clarification.
I just wanted to say congratulations. And thank you for sharing. That's very interesting. Both are very interesting titles. On behalf of AI, I encourage our other members to also start working since like AI is it's on its early stages. I encourage them to actually explore AI and do research as well. It's fresh and the idea is fresh. Like anyone can get of any as I said, we had nociplastic pain and another group had GI, and conferences are actually willing to listen and take the opportunity, as well as like these are also opportunities for those in the US who are unable to work. They can still present on behalf of telegeriatrics. So it's a really good opportunity. Like if you're also busy and you can take a day, one day and just present this, and it's gonna look really good on on your resume or CV. So yeah, this is a really good opportunity for everyone. So yeah, thank you.
Yes, exactly. Thank you very much, Dr. Lejain. Thank you, everyone.
Thank you both. Any other comments or questions, ideas or suggestions?
Dr. Nader?
Yes, please go ahead.
Yeah. So not a new question, but like I was fortunate enough to also contribute to this ACG conference scoping review that is going to be held in Tennessee in October. So I just wanted to give you feedback that I really enjoyed working. It was new. It was a very, very good learning experience for me. And then I look forward to working more because I just realized how much it really impacts me as a new research fellow, and so much learning, so much understanding of how to work in a group. So yeah, that was all. I just wanted to give my feedback.
Thank you so much for sharing this. Yeah, it's important that we share how we develop, how we improve together. So we are learning from each other, and these groups or these teams will give you opportunities to do that. But thank you so much for sharing this,
Thank you
and
so
I'm
much.
very, very glad it's working for you.
Thank you so much, Dr. Nasir.
You're welcome. So I'm gonna close the recording, but for those who might want to stay for more questions, we can discuss. I'd like to thank all the presenters from today's topics. Thank you so much for a great presentation. I'd like to thank all who attended today's meeting and those who will come later on to watch the recording. Thank you in advance. And if you have questions, please feel free to contact me. You can call, text, WhatsApp, or email. I'll be happy to help as much as I can. Dr. Ahmed also will be available at some point. So if anything that we can do to help you, please let us know. We'll see you next week, and have a wonderful day or night, wherever you are.